Good evening, everybody, and welcome all of you to this live program at Orthopedic Principles. Today, our guest of honor is Dr. Jaap Willems from Netherlands. Dr. Willems completed his orthopedic residency at the Leiden University. In 1985, he joined a group of orthopedic surgeons in Alkmaar and moved in 1998 to a large teaching hospital in Amsterdam, where he was requested to become the head of the department in the OLVG hospital. Dr. Willems founded with two colleagues the Dutch Arthroscopy Society in 1990 and also founded the Dutch Shoulder and Elbow Society in 1999. He started an arthroscopy and arthroplasty cadaver course on shoulder and elbow in 1991, which is being run for the 30th time this year. He's been active in several committees as well as the board of directors in the ISACOS. He has served in the executive committee of the European Shoulder and Elbow Society from 2001 to 2010, from 2004 to 2008 as general secretary, and from 2008 to 2010 as the president of the European Shoulder and Elbow Society. He was also honored by the Queen of the Netherlands for his efforts to promote shoulder surgery to become the Knight in the Order of Orange Nassau. If you've noticed, Dr. Willems has delivered a lecture on our channel in the past, and today it's my great honor to bring back Professor Jaap Willems for this wonderful live program. Over to Dr. Willems.
Thank you very much for these nice and kind words, Dr. Gopalan. Today we are going to talk about the scapula, and quite often forgotten part of the shoulder, and I'm going through all sort of pathology. I will discuss a little bit about the anatomy, especially the comparative anatomy, how the evaluation of the scapula happened, and then we will talk about the pathology, both neurological causes of problems with the scapula and orthopedic causes, that bony or soft tissue issues. If we look to quadrupedal mammals, we see a vertical scapula, and these animals, they have no clavicle. They are four-legged, and as I said, the scapula is vertically oriented. The glenoid points downwards, and the humeral head is 180 degrees retroverted to the humerus. And as we know, in humans, it is quite less, as we will discuss later. The clavicle is not needed in these quadrupedal animals. Both that without clavicle, you have a longer stride, the stride of the legs is longer, and it is not required for standing on your forelimbs. It is absent in dogs and horses, but there are other quadrupedal animals, like the graspers and the climbers. They are primates, and in these animals, the clavicle is present. And this leads to the next evolution from pronograde, where the scapula is vertical. It slowly develops in different sort of primates, the gibbon, chimpanzee, gorilla, and the human being, to a more horizontal position. And it is moving from lateral of the thorax cage to the more posterior part. And in all these animals, there is a clavicle present, but it is getting longer and longer when the scapula is moving to the back of the thorax. So the presumed sequence in the development of primates, that they go from quadrupedal to brachiator, where they are living in the trees and using the forelimbs more as an arm with a wider range of motion compared to the forelimbs of the quadrupedal. And in the bipedal, there's the most intense development of the motion of the arm, where it is a completely range of motion of 180 degrees compared to quadrupedals, where it is much less. So that the development of moving the scapula posterior and development of a larger clavicle made it possible that the arm is having such a great range of motion as in human beings. The fascinating part of the scapula is that it basically has only one joint with the body, that is the acromioclavicular joint. The other joint, glenohumeral joint, is not with the body. And it is fixed to the body by 17 muscles, and I'm showing them here: trapezius, levator scapulae, major and minor rhomboids, the serratus, and the minor pectoralis. And between the axis of the body and the humerus, that means the body and the humerus, is the deltoid, supraspinatus, infraspinatus, subscap, latissimus dorsi, teres major and minor, the biceps, long head and short head, triceps, and the coracobrachialis. So all these 70 muscles are fixed in one or two parts of the scapula, and they move. And you can imagine that if there is a balance between some of these muscles, there can be created serious disturbances in the range of motion of the scapula. Talking about pathology, we will discuss the neurological pathology. There are either congenital or acquired diseases leading to a scapular problem. And there are some particular nerve lesions which we discuss separate. The two most important and most well-known congenital pathologies of the scapula with involvement of the scapula is the fascio-scapulo-humeral dystrophy. Basically, the face, the humerus, and the scapula are involved in this muscular disease. And the Spinal is a congenital disease where the development of the scapula is out of order and leading to a malposition and severe dysplasia of the scapula. This is the fascio-scapulo-humeral dystrophy. You see the position of the scapula, and the patient is only able to move his arm mildly forward. He is not able to move it forward. Once you fix the scapula, as you do here, they have a free range of motion. So the extreme winging of the scapula in this pathology leads to a very severe decrease of range of motion. And there are several options, but the most secure option to treat this pathology is fixing the scapula to the thorax. And here I used plates and wires, enabling the patient to move his arm in elevation like we've shown here. This is what you can achieve with a fixing of the scapula to the thorax. Very rewarding operation. The difficult operation, you need bony fixation of the scapula to the ribs. So it takes some time before the plate has done its work and there is a bony fusion between thorax and the scapula. The spinal deformity is an hypoplastic scapula. It's a growth disorder in the scapula. There is superior displacement and there is also rotation. And basically here you see the normal side is in a straight line, and here it is medially rotated. And there is serratus weakness, and you see here, especially when they move the arm, the winging of the scapula. Well, the most well-known procedure for the spinal deformity is the Woodward procedure. Here you see the pre-op CT scan, the winging, the upward position, and the rotation of the scapula compared to the contralateral side. And here, the Woodward procedure is basically a procedure where with a midline incision, the trapezius and the rhomboids are detached and placed more inferiorly, pulling down the scapula and leading to a position which is nearly comparable to the contralateral side. And here it's quite, although not a normal range of motion in these patients, a very rewarding procedure. Sometimes there is a connection between the scapula and the omoid bone, and you have to remove the tight tissue between these bones. And sometimes you have to do a clavicle osteotomy when you have the feeling that pulling down the scapula there is severe stress on the plexus. So sometimes preventively you do already a clavicle osteotomy. An acquired problem with the scapula. The Parsonage Turner, probably well known to you, is a neuropraxia of the brachial plexus. These patients have severe pain, and there is a muscle weakness leading to even to paralysis. And you see here this patient with a very severe atrophy of the infra and supraspinatus. But the pain is on the foreground. It is most prominent is the pain. So the patient come to you with severe pain in the shoulder. There is not always immediately an atrophy, but by testing the shoulder muscles are weak, and the pain will lead you finally to the diagnosis. The EMG changes are not always very clear in the beginning, but later on it is shown that the EMG shows weakness due to several involvement of several muscles and or the brachial plexus. Regarding particular nerve involvement, these are the nerves who serve most of the muscles around the shoulder, and I will cover all of them. The axillary nerve, I will skip, that is the innervating the deltoid muscle. If there is a complete palsy of the axillary nerve, there's a loss of motion of the deltoid and severe decreased range of motion in the shoulder. And there are several options. I will not cover this one. I will cover the last two. These are the most interesting. The spinal accessory nerve. It serves the sternocleidomastoid muscle and the trapezius muscle. The cause can be a direct blow, but quite often it is iatrogenic. You remember the stories of a young resident asked to remove a lymph node for the neck, not knowing very well the anatomy, and cutting this branch of the spinal accessory nerve. And here the branches to the sternocleidoid, and here the branches to the trapezius. And quite often this branch is involved when removing lymph node in the neck. And here you see the difference with the weakness of the trapezius on the right side. The option for this pathology is the Eden-Lange procedure, where the levator scapulae is detached here and placed on the scapular spine. And here the minor and the greater rhomboids, normally attaching at the medial border, placed and transferred more lateral to the scapula. And I show you an example. Male, age 28 years old, pain in the right shoulder since 1 year. 1.5 years ago, had a trauma, a jaw fracture, and probably with involvement of the accessory nerve. The MRI of the cervical spine was normal, and the EMG showed only the innervation of the trapezius, so the distal part of the nerve was involved. And here you see the lower, the atrophy of the trapezius compared to the contralateral side. So this is the most prominent phenomenon. If you examine the patient, you see here there's normally a rather normal range of motion, but you see the difference in the position of the scapula compared to it's a minor difference. The patient is complaining of weakness of the shoulder, is losing strength in the trapezius muscle, is really a nuisance. And here you see the atrophy. And if you look to the MRI, that is you see here a very thin atrophy of the trapezius muscle. And if you compare it with the contralateral side, that is the trapezius muscle, and it is in the involved side, complete atrophy. So it is not going to recover by doing a nerve transfer. The only effective treatment is a tendon transfer. And here you see a picture, patient is prone position. Here the minor and major rhomboids are detached, and here they are placed. That is here is the medial edge of the clavicle, and here it is affixed to the clavicle with drill holes, several drill holes, sutures passing as a mattress suture through the scapula and fixing with not tying the tendons here on the scapula. And it is very rewarding. This was the pre-op position of the scapula, and it is 3 months post-operatively the normal position of the scapula compared to the other side. The long thoracic nerve is quite often, and probably you have seen it in your practice, it is the longest nerve in the body, either a direct injury or stress to the nerve where it runs in front of the thorax. It can be iatrogenic during surgery, or an isolated Parsonage Turner, where not all muscles involved, but only this nerve and leading to a painful winging of the scapula. It is basically an involvement of the serratus muscle, which is not functioning. Here, the serratus muscle fixed on the interior side of the scapula and moving the scapula in a normal position. But with weakness, the winging starts. And here you see one of the tests is with stretched arms to the wall, pushing away. Then the scapula, the serratus weakness shown here with the winging of the scapula. Either pressing against the wall or pushing against the arms of the examiners, as shown here quite clearly the winging of that scapula. A case, a patient with a fall on the right shoulder in 1999, a 24-year-old female, a professional cyclist. She had a subcapital or either 3 fragment fracture. I haven't seen the X-rays. It was treated conservatively. The head remained inferiorly subluxated, and there was an osteotomy performed. People thought, well, the malunion is leading to this subluxation, the inferior subluxation. And here you see the 3D CT scan, malunited with inferior subluxed. So they thought that an osteotomy would do well. Well, they did an osteotomy, but basically there was quite soon after the surgery, again, a subluxation as shown here. This is in the normal resting position where there is a subluxation of the head. And here you see the position of the scapula. So there were nerves of the plexus involved in this case. And if you push the arm back into the joint, this is the normal position. The AMG showed a partial inferior plexus lesion with involvement of the long thoracic nerve. So what we did in this patient is the standard treatment, the pec major transfer. Either you take 1/2 of 2/3 of the pec major and you bring it just over the thorax cage to the inferior part of the scapula. And here you see the tendon of the pec major. You have to lengthen it with and I used here an allograft iliotibial tract, but you can use other tendons like the hamstrings, a double hamstring. So making it longer and enabling you to drill a hole and to pass it through and then fix it to itself. That is very, very strong fixation. And that is the end situation in the normal resting position. There is a normal position of the scapula again by the pull of the pec major fixing the scapula to the body. And there was a normal full range of motion, nearly full range of motion in the shoulder. Orthopedic causes of scapular problems. Well, fractures is a wide area. I could cover another hour on the fractures of the scapula, so I will skip it. Maybe for a later session with Dr. Gopalan, we can discuss scapular fractures. They are quite interesting issues. Another problem can be the exostosis leading to a snapping scapula. Like you see here, an exostosis of the scapula. It is quite easy to find it on your CT scan, quite easy to treat. And by removing of this exostosis, I have some patients, and the surgery is very rewarding, completely free of any symptom after the surgery. Muscle problem, the disbalance. We discussed earlier, there's so many muscles around the scapula that easily can arise by whatever reason, either surmenage or overuse of some of the muscles or underuse of other muscles, leading to a disbalance in the scapula, leading to a scapular dyskinesia or scapular disbalance, leading to pain and less function of the shoulder. Talking about the snapping scapula, it's quite easy to find. There's a palpable and sometimes audible crepitus supermedia of the scapula, quite voluntary with elevation of the arm. There can be pain in the region of the crepitus, and in most cases, this snapping scapula is unknown. There are not always bony lesions. There can be a bursitis underneath the scapula or just a dysfunctional movement leading to subtle anatomical abnormalities. And here I will. This is the case where clearly, and I hope you can hear it, a clear audible crepitus between the scapula. Well, it is important to exclude major bony abnormalities such as an exostosis. And in most cases, bony scapular changes are subtle or absent, but you have to look for it. This is a study where they measured the angle between the scapula and the spine, and where this angle should be between 142 and 169. So the angle of the supremedial scapula can be increased, and that leads to more contact between that area and the thoracic cage. Here's an example where you see the normal curve of the scapula and the superior scapular angle, and here there is a bit difference, and there can be like in this example, if the angle is increased, it can lead to contact to the thoracic cage. So you have to perform bilateral CT scan if you suspect this malformation of the scapula in the superior part, and it is a quite easy procedure to remove that part of the scapula. So the treatment is either surgical, an open excision, or an arthroscopic incision, arthroscopic approach, and the removal of the bone is quite easy if you consider the nerves that are around the shoulder. And here the patient where this is the superior portal, and this is the medial portal, and this is from superior. There is a nerve running from superior to inferior, but as long as you stick to the medial angle of the scapula, that is the direction of the spine, that is from superior, this is where the nerve is running. And then if you introduce your scope from superior, stay away from the nerve, this is the body of the patient, that is the arm of the patient. So that is the medial, supermedial edge of the scapula, and trocar and shaver, and looking from here, you can remove the bone in this triangle. And that is as long as you stay away from the nerve, which is halfway between lateral and medial border, where the cutaneous branch is running. You can easily approach with the scope, looking and bringing in the scope, you palpate the superior edge, you go underneath, the same you do from here, and it is quite safe. You hardly ever can perforate the thorax when doing this. Looking upward, you remove the bone, you remove first the bursa, and then you remove the bone from this part of the scapula. So that is basically, if it is really protruding, if you found it out on your CT scan, you can easily remove this piece of bone. It is basically, if you have the proper portals, a subacromial decompression at the medial side of the scapula. What about muscle balance? This is a patient, and we could not find out what the reason was, but basically there is a severe wing of the scapula, I think caused by a severe traction of the pec minor. If the pec minor is pulling hard on the scapula, it will get another sort of winging, and here there must be serratus weakness as well. EMG didn't show any abnormality, so this was probably voluntary adapted, like we have the voluntary subluxators and luxators of the shoulder, where you can't find any pathology, but they managed to develop a strange sort of scapular dyskinesia, and it takes quite some time with a physiotherapist to retrain these people and together to achieve a normal range of motion in the shoulder. But Kepler is the one who's paid a lot of attention to all sorts of scapular motions and all sorts of pathology of the scapular motions, especially related to sports. He defined 5 directions of movement in the shoulder. Translation is basically a motion where the scapula is going over the thoracic cage, moving and translating. And And medial lateral is a movement where it is just running over the thorax from medial to lateral. And rotation is where it is not moving over the shoulder, but tilting up and downward, tilting up that way. That is the upward and downward rotation. So it's not a gliding, but it's really a rotation. This is gliding, and this is upward rotation, that is downward rotation. And you can have that in internal and external, like you see here. This is the sliding motion, is the translation. I should discuss where, if you look from the back, it's called either internal of external rotation. And then finally, there is the posterior tilt and anterior tilt. Sorry, coming back here. The posterior tilt, where is a tilt from posterior to anterior rotation, and this is the posterior and anterior tilt. So I made a mistake. The rotation is downward rotation where the glenoid is rotated downward, and upward rotation where the glenoid is rotating upward. Posterior, anterior tilt, that is this motion where you tilt it posterior or anterior, and internal rotation is internal, external. If you look to the scapula in this normal position, it is upward rotate, the glenoid is rotating upward. There's a posterior tilt, that means that is tilted upward, and there is an upward rotation going to the where the glenoid is going upward. In scapular dyskinesia, there is an altered position and an altered motion, and quite often we see it in athletes, and we call it protraction. Basically, there's an internal rotation. The scapula rotates inward towards the patient, not external, but inward. So there is winging. There is less upward rotation. The glenoid is facing downward. And there is an anterior tilt. The scapula is tilted anterior over the scapula. So not a translation, but really a tilting. So this is coming away from the thorax, and this is going to the front. So this combination you see very, very often in athletes, and we call it protraction. So keep in mind the internal rotation, the less upward rotation, more or less downward rotation. And you can imagine that if you lift the arm, you elevate the arm in this position, you quite easily reach the maximum. You can't reach the maximum of abduction. And you have to doing sports, throwing or swimming whatsoever. So this leads to a secondary impingement of the arm against the acromion. So it's not a primary impingement due to acromial changes, but it is a secondary impingement trying to abduct as far as possible, but unable to reach maximum, and you push the cuff against the acromion. And the mistake very often made in these patients with the scapular dyskinesia is that the subacromial decompression is performed, which is not helpful at all. The balance of the scapula should be restored, and there are several ways to do it that you can easily find on the internet, but basically I will discuss it later. The cause of this protraction weakness of the serratus, it can be tightness of the pec minor, or it can just be posture. If you have a severe kyphosis, there is automatically a forward position of the scapula leading to secondary downward rotation. So patient, if they have a kyphotic posture, and if you see patients with a senile kyphotic posture, there's quite often also a limited range of motion because of the secondary dyskinesia of the scapula. So the impingement, as I said earlier, is because the glenoid is directed inferiorly and anteriorly. And during abduction, there is stress on the posterior superior structures. And Burkhardt introduced the terminology sick scapula. That means there's a scapular malposition, there's an inferior medial border prominence, the inferior and medial border prominence. There is pain at the coracoid, probably related to the pec minor tightness, and there is dyskinesia of the scapular movement. So it leads to problems with the inferior aspect of the supraspinatus and the posterior superior labrum. That is, if you see this picture here, quite often they have a decreased and internal rotation. That's what is called the GERD, gleno-humeral internal rotation deficit. So it's quite often combined with the sick scapula. And it needs conservative treatment, basically by stretching the posterior capsule, stretching the pec minor, and training of the serratus muscle by exercises of bringing the scapula together is training your scapular muscles and lengthening your tight pec minor. How to examine the scapular dyskinesia? There are two very important tests. Well, first of all, you have to look to the posture. How is, because as we all know that the throwing motion, it is a chain of motions from the foot till the shoulder. So you have to look how the hip, trunk, and shoulder and legs act, if there is any disbalance, and then look to the shoulder. And these two tests are very helpful in finding the scapular dyskinesia. If you assist the scapula in assistance and put your both hands around the scapula, the patient normally can move and elevate his arm further. So this is just pushing back the scapula in a normal position. Regarding the internal, as showed earlier, the internal rotation of the scapula, if you fix it here, so you retract the scapula, that is, and if the patient is able to elevate the arm in a better way, then you know that the main problem is in the internal rotation and the upward rotation with this malpositioned scapula here. If the main problem is here, then the rotation of the arm is more involved. So these two tests can distinguish a little bit easier which is the most important part in this dyskinesia. Is it the rotation, or is it inward rotation? Is it the downward or upward rotation? Is it inward and external rotation, or is it the scapular tilt? So I advise you to try these tests in every scapular dyskinesia and find out which leads to less pain and a better range of motion in this patient. Well, another important point of examination, especially where the scapular dyskinesia is not very prominent, is to ask the patient very quickly to elevate the arm 10 to 20 times. And then so you overuse, you exhaust the serratus muscle, and then quite often the winging of the scapula is becoming obvious, as you see here. Quite quickly, it is shown here. Normally, it increases when you perform this procedure several times. So the treatment is core training. Well, patients have to have a good balance of the legs. So you have to train it. The GERD, that is traction of the posterior capsule, as you shown here, of the posterior structures of the shoulder. And these muscles are mostly involved, so the pec minor and the serratus muscle. And that is the most important part of the treatment of the scapular dyskinesia. So coming to a conclusion, the scapula is a unique part of the body. It is involved in many shoulder pathologies, and I could not cover for time reasons all of them. but a careful examination is a very important part of the shoulder evaluation. If I may, I would like to show one case, well, where not as much the scapula is involved, but it is very important to examine the scapula before you decide something else. Is there time for one case?
Yes, Prof, you can go ahead.
Okay, then I will look for it quickly. I will share the screen again. Quickly close this one. Sorry, I can better do it this way. I have to close. Can you see it?
Yes, Prof.
Okay, I will. It is a very simple case, but stressing the importance of looking to the scapula. This is a male, 48 years old, an entrepreneur, very active guy, very sporty. In the end of 2040, he had a fall on the left shoulder during field hockey. In hospital one, well, actually his business was making drones. Sorry, that was the reason I put a picture of the drone. In hospital one, and they found an AC dislocation Rockwood 2. And as normally we do, we follow conservative treatment. The shoulder remained sore, painful, and he returned to the hospital some months later, and they didn't know what to do. They said, well, it is a Rockwood 2. They started conservative treatment with the physio. The pain continued. He went to another hospital. They didn't make an X-ray. They had, well, there is a Rockwood 2, so what is the problem? We don't know. So they couldn't find out the reason. So they went on with conservative treatment and physio. So at the end of 2015, so nearly a year later, he came to my hospital and I examined him. And he said, "Doctor, you are the first one looking to the back of my shoulder. No one looked to the back of my shoulder." And you see here quite a severe atrophy of infra and supraspinatus. And then look to the X-ray. Well, they didn't. They did look to the X-ray. They said, well, there was some calcification that is normal in the grade 2 dislocation. So what matters? So, well, immediately, and probably you know already the diagnosis, there must be problems with the suprascapular nerve due to the bone. Interestingly, if you look to the other side, there is here a bony ligament. Normally there is a ligament, but here there is a bony structure. As you see here, quite interesting. That is not very frequent the case, but that is a coincidence. There might be, well, I will discuss later. The biggest problem is here. That is, the ligaments are normally between the coracoid, the base of the coracoid here, which is very close, as you know, to the ligament, transverse ligament from the suprascapular nerve. Here are the ligaments running to this tubercle, and here. But interestingly, the ossification in the hematoma, is always in the hematoma, was quite far medial, which is quite exceptional. I operated him with a neurosurgeon, and here is a detailed picture. Well, the picture is not completely normal because the clavicle, this is the clavicle, the nerve is running from here, behind the clavicle, sorry, behind the clavicle to the incisura, where the ligament is. Well, we started to look for the nerve where it was in a normal tissue, and we followed the nerve, and here it is freed, where there was all bone around it. So it was very careful release of the nerve. But when we finally had the nerve free, it looked very compressed and it didn't look very, very normal. There was no activity when stimulating the nerve here. There was no muscular activity. So very probably, and the neurosurgeon expected the nerve to be dead. The result was that after 4 months post-operatively, there was no pain, there was a full range of motion, but there was the same atrophy, only mild weakness during his activities with field hockey, where, as you know, the cuff is not that important compared to when you do throwing sports like basketball, baseball, or swimming. So the patient was very happy, but as you see here, there was, and we did see it during surgery, here is the hole of the suprascapular nerve, and here there's also an ossified ligament. So it was a coincidence. They had a completely normal suprascapular nerve before, but that is, with the message of this is, if you examine the shoulder, always involve the scapula in looking to pathology. So I start as a routine in all my patients, first look to the back of the shoulder. If there is a normal position of the scapula, symmetrical position, if there is some atrophy or not, and then I turn to the front and look to the scapula and look to the range of motion and other pathology in the front of the shoulder. So that's the end. I thank you.
Thank you very much, Professor.
Your attention.
Yeah.
Yeah.
Thank you very much, Professor, for that fantastic lecture on an overview. Actually, you've gone into detail about a lot of conditions. A couple of questions from our side, Prof. Just to recap, because we have a lot of young surgeons, residents, fellows who watch this program, I just want to look into the causes of scapular winging. For example, one is a serratus anterior deficit, and the other one is trapezius, and the third one is the rhomboids, the levator scapulae and the rhomboids, right? So these are the three common situations that you get a scapular winging, isn't it?
Yeah. And it is a winging in a bit different direction.
Yeah.
The scapula alata of the thoracic nerve is just a winging. And in trapezius, there is also a rotation of the shoulder, and the rhomboid as well. But the scapula is coming from the body. That means it is winging. That's correct. Yeah.
Thank you very much, Professor. And the other very important terminology that you mentioned, Ben Kibler's research on scapular dyskinesia, right? Yeah. So if you want to give some take-home points to someone who's watching the channel about scapular dyskinesia, one, regarding its clinical relevance, for example, one, you said some people may operate it for assuming that it could be a rotator cuff disease, and ultimately it does not give any relief, right? So that is one clinical scenario.
Yeah.
And the other important message, I think, is one of the most important treatment methods for scapular dyskinesia is still rehab, isn't it?
Yeah, absolutely.
And any other clinical situation where you think scapular dyskinesia is, I mean, you mentioned a lot of information. What are the other clinically situations where you're going to have a diagnosis of scapular dyskinesia?
Well, most probably you will see it in the cricket players in India. I have heard that in cricket, throwing the ball, that there's an extreme range of motion, even more than in basketball or other sports. And there, if there's not a good balance, you easily can get an athlete's shoulder of a scapular dyskinesia. Well, the examination is the most important. Look to the test I showed. Look to also the winging. Check the pec minor if it is tight, and if there is difference in position of the coracoid, or if the coracoid is painful, so look to the coracoid. And well, I showed several pictures of the scapula, how it can wing, and try to exhaust the shoulder. Try to have the patient doing several exercises to exhaust it and see if it becomes more prominent. And sometimes I ask the patient, if they complain after a sport and I can't find anything, please play a game or go to a training session, and immediately afterwards come to me, and then sometimes it's more prominent. So cricket players, there are not many jobs where you have a scapular dyskinesia. It can happen if you have full-time overhead jobs where one of the muscles can get tired and lead to scapular pain. And most often it is more overuse and overexhaustion of the rotator cuff, leading to rotator cuff tendinopathy. But sometimes there is a combination. They have rotator cuff tendinopathy, and due to that, they try to avoid the rotator cuff, the exhaust other extra shoulder, extraglenohumeral muscles, and leading to a secondary scapular dyskinesia. So it can be a combination.
Thank you very much, Professor. Just one last question before winding up the session. Have you encountered isolated infraspinatus atrophy? For example, I had a case where a patient was complaining of long-standing shoulder pain, and when I examined him, he had an isolated infraspinatus atrophy. Then after detailed examination, I took x-rays, I couldn't find anything. Then ultimately, I understood that it could be a ganglion cyst of the spinal glenoid notch. Have you encountered these cases?
Yes, there are a very good question, because it is one of the issues probably I forgot to mention. Indeed, the spinal glenoid cyst might be a possibility leading to isolated palsy of the suprascapular branch going to the infraspinatus. But it has been shown also, especially in my country, in volleyball players and maybe in other overhead sports, where there is no spinal glenoid notch, there is no what some have seen, a very rare ligament in the notch leading to compression of the nerve. No way, but some blame it at the severe hypertrophy of the infraspinatus leading to compression of the nerve, like in a compartment syndrome in the lower leg, leading to a compression of the nerve, neuroplaxia, and then secondary leading to atrophy of that muscle. So that is the cause which might be the final one if there is no spinal glenoid notch, no anatomical strange structure leading to compression of the nerve. So very important point, Hitesh. Yeah.
Thank you very much, Professor. I think that's all the questions that we have for the session. Thank you for yet another fantastic talk, and I'm sure this is going to benefit a lot of people, Prof.
Yes, thank you very much. I wish you all a good night, and hopefully see you soon again.
Bye-bye, Prof.
Bye-bye.